And I would like to welcome all of you for this webinar of the Academy of Assisted Reproduction, Trichy, Tanjavur, and Tiruvarur. We are actually a society which works for people who are in reproductive medicine in the southern districts of Tamil Nadu. And we usually conduct only through webinars, and we get esteemed speakers and researchers doing original work. And it's my honor to welcome the speaker for today, Dr. Kundan Ingle, known for almost 1 or 2 decades now. And I know that he's a very, very passionate worker in reproductive medicine because he does not take anything at face value. He tries to work it out. And we have heard his talks, which are all quite original. And it's all based on Indian studies. So we get some inputs which will help the regular clinician as well as the student of reproductive medicine. So I would like to welcome Dr. Kundan Ingle for this program. I'd like to welcome all the delegates who have joined and the office bearers of this society, Dr. Jem Kannan, who's the vice president, Dr. Manjula, who's the treasurer, and Dr. Shanti Priya, who's the EC member. The others will be joining a little late. And we have got some regular delegates always who interact so well at the end of the program. And we have always have only one esteemed speaker, and we have an interaction with him or her at the end of the talk. So may I request Dr. Manjula Appathurai to introduce Dr. Kundan Ingle formally.
Welcome you, sir. Dr. Kundan Ingle. Sir is HOD, Vishwaraj IVF Center, ADAP, sir, Pune. Chairperson AMOX Endocrinology Committee 2024 to 26, Chairperson Infertility Committee FOXY 20 to 23, MC member ISA 22 to 23, Director Nirmiti Clinic Center for Assisted Reproduction and Endoscopy Pune, Vice President FOX 23 to 24, Founder Treasurer Maharashtra Chapter ISA 2011 to 14, presented research paper at ASRM 2020 on prospective RCT of estradiol valerate versus estradiol hemihydrate in FET. Owner Moses Cradle ART Bank, Pune. Presented first time research at 6th COGI World Congress at Vietnam on the use of GCSF subcutaneously for thin endometrium. Over to you, sir.
Good evening, everybody. I hope I'm loud and clear.
Yes.
First of all, thank you very much, Dr. Charmila and the whole organizing team, and especially the office bearers of Academic Wing of Assisted Reproduction for inviting me to speak in front of all of you who are, I heard, are pure academicians, and it is my pleasure to present you my research work on endometrial preparation for assisted cycle. So friends, I think this is the topic which is, I think, very close to us because we know it is very, very useful and it is everyday's practice. We all utilize these kind of protocols. And since 2015, I distinctly remember the frozen embryo transfer cycle protocols, or this technology has come into role because of the lot of research and development into vitrification and thawing techniques. And then we realized that, yes, this is going to revolutionize our success rates into our field of IVF. And over the time period, we learned how to optimize the success rate in FET cycles. So one of the very important part of this treatment is endometrial preparation. And I always feel that it is necessary because we want to avoid this, that we undergo one cycle, we fail, we undergo second cycle, we fail, we undergo third cycle, we still fail, and at the end of 3 cycles, we actually give it off. The patient also give it off, and we also give it off. And sometimes they're absolutely clueless, and we never want this kind of situation. So friends, this saying, which is always in our mind, is perfection means not perfect actions in a perfect world, but appropriate actions in an imperfect one. So this field is really not 100% perfect, and we have to understand that what is going to be our appropriate actions so that we really achieve for what reason we are doing this work. Now, spectacular achievement is always preceded by unspectacular preparation, and that's what is we have to understand today. Now, I'm bringing you this particular paper, which is since 2014, which is a Cochrane database review, systematic review, which clearly says that final oocyte maturation triggering with GnRH agonist instead of SCG in fresh GnRH antagonist IVF cycle will prevent OHSS and to the detriment of the live birth rate. And women who is undergoing fresh autologous cycles, GnRH agonists were associated with a lower incidence of mild, moderate, and severe OHSS than what was there with SCG. So yes, we understood from this paper that yes, we can use GnRH agonists as a trigger and we can go for a freeze-all cycles. Now again in 2017, what we realized that the total number of deliveries from all FET cycles where embryos were thawed were higher in the antagonist group compared to agonist group. And for the subgroup of obese women, the cumulative birth rate was significantly higher in the GnRH antagonist group. So our first preference always been antagonist cycle, even if it is frozen embryo transfer or frozen thaw embryo transfer cycle, because it gives you better number of better rate of delivery. And also in obese group, we get a cumulative birth rate which is higher. So our favorite is GnRH antagonist and agonist trigger. Now, when it comes to after doing this, when it comes to FET cycle, that is, we want to transfer now this frozen embryo, where we can do a optimization. So to optimize, to maximize our success, all these parameters are important. So your case selection is important. Your pre-FET workup is important. Then after that workup, you have to decide, do you need an optimum reconstruction by hysteroscopy or laparoscopy? Then comes our main topic of today's discussion is the selection of proper endometrial preparation protocol. Then what should we do during FET cycle? Shall we transfer a cleavage stage or shall we transfer a blastocyst stage? Then comes role of progesterone monitoring and luteal phase support. So starting from case selection till the luteal phase support, everything we are going to discuss today. Now this was in 2018, which clearly showed us that though freeze-all strategy is, we were thinking that yes, now we can apply to all patients and we will achieve a better pregnancy rate or live birth rate. But this paper gave us a clear insight, which was analysis of 82,935 cycles. And they realized that only patients who are higher responder, who are going to give us more than 15 oocytes, there, if you apply this strategy of frozen embryo transfer, then clinical pregnancy rate and live birth rate are all significantly better and higher and in favor of FET. But that is not applicable in intermediate and low responder. In fact, if you look at the low responder patient group who is giving you less than 5 oocytes, what they realize that in a fresh embryo transfer, you have a much better clinical pregnancy rate and live birth rate than even frozen embryo transfer cycle. So when you select a case for FET, I think when we are discussing about optimization of live birth rate, you have to select and apply this strategy or technology only for hyper responders or responders specifically who are going to give you more than 15 oocytes. Then comes pre-FET workup. Now, when I say pre-FET, see, remember, a successful implantation is our success in the IVF. And for successful implantation, we need two very important pillars. And that is, one is a competent genetically euploid blastocyst. And second, you need a good endometrial thickness and blood flow. So we need a seed and we need a soil. And it is very important that we need to understand that how can we evaluate endometrium prior to our FET cycle protocols. So there are two ways. You can call the patient on the day of ovulation or anytime after ovulation, or on the day of day 16 of in unovulatory cycles when you have given exogenous estrogen. So when you are seeing an unovulatory patient, what I recommend is we start giving them estrogen right from second day in an incremental dosage. So first 3 days you have given twice a day, then next 3 days TDS, then you next 3 days is 4 tablets per day, then next 3 days 5 days, like that till 16th day. And you call the patient for color Doppler and 3D sonography and 2D sonography. You measure endometrial thickness on that day. It is around roughly 10 millimeter below the top of the fundus. Look at the pattern of endometrium, assess the endometrial blood flow. What you need to assess is typically in a subendometrial region, as you see in this diagram, that in a subendometrial region, you see or note down how many color Doppler signals which are arterial you are going to see. and you measure a pulsatility and resistance index in arterial signals, where your pulsatility index in subendometrial vessels should be less than 1 and RI should be less than 6 and PSV should be more than 10 centimeter per second. So if you have such kind of picture, what you are seeing in this third picture, where you have a uniform growth of endometrium from fundus to internal os, triple line in pattern, having say good 30 to 35 color Doppler signals and getting all these value, you can say that this endometrium has got no problem. And if we transfer a competent euploid blastocyst, it will surely implant. But if you have something like this picture, now as you see endometrial blood flow I was talking about, we have to look into this subendometrial region rather than zone 1 and zone 2, which is myometrial region. So like that, we must see a good number of vessels. Even if you look at the left picture, there are signals which are going right away into the central hyperechoic line. So that's again a very positive sign that if you have a endometrial with a power Doppler signals going up to the endometrial hyperechoic line, that's a very good sign that the blood flow is good. And this, if there is a successful implantation, even the rate of ongoing pregnancy rate is going to be much better. Now, this was a study in 2014 which showed that if a patient who had good flow and it was compared with a very low flow, yes, there was significant increase in the pregnancy rate, clinical pregnancy rate, and the implantation rate also. So a lot of people still believe, or a lot of our colleagues in India still believe, that there is no need to measure subendometrial blood flow in every patient. And I am in belief that no, if you want maximum ongoing pregnancy rate, then you must focus not only on endometrial thickness, but also on the endometrial blood flow. And as I mentioned, which we will discuss in few slides, how should we measure and what will help us if it is not good, how we can improve. Now, this was in 2024. This study actually analyzed 197 frozen embryo transfer cycle pregnancy patients who were pregnant at the end of it. They realized that 70% were pregnant. So what they did is they formulated a kind of a ultrasound index for endometrial assessment, where endometrial morphology, endometrial blood flow, endometrial thickness, volume, FI, that is flow index, frequency of endometrial peristalsis, and depending on these findings, they assign a score. And at the end of it, after summing the score, they found out that if you really assess this way, then if the score is above 6 and above 6, then if you look at the clinical pregnancy rate, it is significantly going from 52% to 70%, and it is still further goes if the score is much better. So if you look at the 100/11 score, the clinical pregnancy rate is 100%. Okay, so I think this particular score, which you can see, they considered each different parameters, and depending on the value, result value, they have assigned the score. And I think it's a good score, I feel, but it's not necessary that if we follow this, but looking at this particular graph, you can actually predict if the score is that good. So you can actually predict how much will be the success in future. And even as in the next diagram, if you look at it, there is a significant change in the clinical pregnancy rate, and it is in favor of that once the score is above 6. So you assess the endometrium in these parameters, and then you label whether I need to interfere before embryo transfer, anything to do with endometrium to improve, or it is fine, I can safely go ahead and transfer a good blastocyst in this endometrium. Now, this diagram, which is showing us first on the left side, that you can see the endometrial glands, then there are vessels. So if you look at these particularly mesenchymal-like stem cells, which are located alongside the blood vessels, there are putative epithelial stem cells which are located along the endometrial glands. Now, this is called an endometrial niche area. Now, these endometrium and these are called progenitor endometrial stem cells, and the one which are on the blood vessels are the hemopoietic stem cells. So they actually proliferate and they develop the endometrium every month. They are the one who are responsible for the neoangiogenesis in the endometrium, and that improves. Now, if you look at the right diagram, if you look at, there is a break into this endometrial niche area, which happens because of deposition of fibrous tissue. there is a loss of endometrial stem cells migration, and that is actually leading to lesser endometrium development, or you have a lesser angiogenesis to the endometrium or less blood supply to the endometrium. This is a very common thing, especially in India, because we have lots of, almost, if you look at the thin endometrium patient, 40% patients are having chronic endometritis. And in chronic endometritis, there is a fibrous tissue deposition into this endometrial niche area. And that's why even if you have a good stem cells, probably they are not giving you adequate response of endometrial proliferation and neoangiogenesis. So in these patients, what we realize is, or what we see is, that their uterine cavity volume is compromised if you check the 3D. So it has been documented that if the endometrium volume, or it is called as uterine cavity volume by 3D, if you measure, and if it is less than 3 centimeters square, then it is associated with a significantly lesser implantation rates. But this, this you can assess it when you are assessing the endometrium, as we discussed, and you select your patients. You select their endometrial, depending on endometrial thickness, blood flow, and volume, and then decide whether hysteroscopic lateral metroplasty, which consists of incising the lateral walls as well as the fundus to obtain the enlargement of uterine size and improvement of the uterine shape. So this is how the procedure is done. Hysteroscopically, what you do is you cut the fibrous tissue till you see a good blood vessels. As you see in this diagram, there are blood vessels which are exposed very properly after cutting that fibrous tissue inside. So it is very important that you need to get these vessels submucosal or subendometrial region. So you need to dig into the lateral walls or at the fundus till you see a good number of subendometrial vessels. Now, you will always think that this may lead to a fibrous readhesion formation, where you, with the use of estrogen and progesterone later, you can safely develop an endometrium right from the day of surgery, and this will prevent the readhesion formation. And out of 100, only 3 to 4% patient, you will see that there are readhesion formation on this operated areas. But otherwise, it gives you a fantastic picture, as you will see in a future slides. Now look at this patient. This is one of my patients who were having a very thin endometrium, and it was only 4.8 millimeter, as you see on the left side. And if you look at the 3D picture, the volume of the cavity was only 2.06 centimeters square. Now the volume is less, the endometrium is thin, the blood flow is very scanty. Now in the same patient, when we did a lateral metroplasty and even fundoplasty, this is what is exactly a next cycle picture, where endometrium is grown up to 8.7 millimeter. And if you look at the blood flow, the peak systolic velocity has gone to 10.78. And if you look at these vessels, you have good number of vessels approaching now towards, because your lateral metroplasty not only enlarge the cavity, but it actually induces the injury, which induces the inflammatory response. So we get a good pro-inflammatory cytokines, and we get a kind of a inflammatory response in terms of increasing the angiogenesis in this area. And that is how we get a good blood supply to the endometrium. And if you look at the 3D picture of same patient, now the volume has increased from 2.08 to 4.25 centimeters square. And look at the endometrial picture also, the thickness is better. And now I feel that this patient is ready for frozen embryo transfer. So when you discuss about endometrial preparation, it actually starts right from before embryo transfer. That is your evaluation point of view. Now, this was a minimal invasive journal publication in 2020. It was a retrospective multi-center trial where there were patients who were selected having primary unexplained infertility or repeated early miscarriages. And after this kind of procedure like hysteroscopic metroplasty, 60 months later, that comes to somewhere at the end of 5 years, overall clinical pregnancy rate in such patients was almost 73%, and live birth rate was almost 80%. So, in fact, if such kind of unexplained infertility patient only having this issue, if you just do a hysteroscopic metroplasty for selecting, after selecting properly, Then 47% conceived spontaneously in within 5 to 6 months after the procedure. And I think that is very, very encouraging. So another study in 2020 of 937 patients, it was a systematic review and meta-analysis, and they wanted to judge the reproductive outcomes. And they realized that in patients with especially recurrent miscarriage, the miscarriage rate was significantly less. If you look at the live birth rate, was significantly improved even in infertility patients as well as in recurrent miscarriage patients, and with a very minimal complications of 0.65% surgical complication. So it's a very rewarding surgery, especially when you see a thinner endometrium, low subendometrial blood flow, or low endometrial volume patients. Now, after correction of these all endometrium factors by way of hysteroscopy, and now the time comes when we prepare our endometrium for embryo transfer. So how will you prepare? So these are the 4 protocols. The most, if you look at it, commonly you can divide it into 2 mainly protocols. One is called natural cycle, and second one is called artificial cycle. Now in natural cycle, you can have a slight modification by using SCG instead of having endogenous ovulation or her own spontaneous ovulation. You can control the ovulation by giving SCG. In artificial cycle, there is still modification where you can down-regulate and then do an artificial cycle. But it is very important that to do a natural frozen embryo transfer cycle, you need our patient to be ovulatory patient, because we are dependent on her own follicular growth. But in when natural cycle is not possible, when patient is anovulatory, like polycystic ovarian syndrome patients, or probably those patients whose periods are very late, there is no follicular growth, how can we depend on natural follicular growth in that case? So in that case, either you can do a mild ovarian stimulation protocol, where with maybe oral ovulogens or very low dose of HMG, you can develop the follicle and you can give SCG and plan transfer. Or else best in anovulatory patients is the HRT protocol. Now we need to compare these 2 protocols, because there is a lot of debate in last 1 decade that which is the best way. Now in natural cycle, duration of estradiol production, which is happening from the follicle, is dependent on the follicular growth. Yes, we know, means the follicle, if it is good quality, it will produce the adequate amount of estrogen. So what is adequate amount? Is serum estrogen levels at the end of follicular development. Estrogen level should be reaching to 125 to 200 nanogram per ml, because that will give us adequate exposure to the endometrium of estrogen, and estrogen and endometrium will respond to such good levels. But if these same levels are below 100, like 60, 70, you will see the endometrial thickness and growth is compromised. So if endometrium is thin, less than 8 millimeter, even if you wish, you cannot wait for adequate embryo transfer, endometrial thickness. So this is what happens in natural cycle, because we are following follicle size, not the endometrial thickness. Okay. And we have to plan our embryo transfer as per the natural ovulation. But that is little, that control we have it in HRT cycle, where suppose you do not have a adequate endometrial thickness achieved, you can prolong with estrogen administration for a little longer time. And HRT itself, giving estrogen itself, is going to prevent follicular growth, and duration of estradiol supplementation is completely under our control. So even if it is required for a longer time, like 21 days, 25 days, or even 30 days, you can use that time because this time our decision to start progesterone depends on how much endometrial thickness. It is no more on the follicular growth. So that is a major difference in these 2 protocols. Now, how natural cycle protocol? Let's understand diagrammatically. So once the patient reports your first day of the menses, 9th day of the menses onwards, you will ask her to start monitoring urinary LH monitoring. So the moment you will see positivity in the urine LH kit, you will understand that the LH surge has happened today. Okay. So that day you will skip, or that day you will send the serum LH levels. And once you document the serum LH levels that is gone beyond 10 MIU, then the LH surges happen, and you will consider that as a first day of LH surge, and then you will transfer the embryo according to the progesterone levels. Now that how much duration after progesterone level you will transfer blastocyst or cleavage, we will discuss it once we reach to that level. Now, in very important in natural cycle, you have to understand that you are dependent on patient's LH surge, and that LH surge detection is dependent on your patient's urinary LH kits. And once the LH surge is documented, you have a choice of checking the LH levels so that you are sure. And once it is more than 10, then you can count the days when you want to transfer them. But as I said, it is only possible with ovulatory patients. Now, what modified natural cycle protocol? Here, what we are doing, it is similar protocol, but here from 9th day onwards, we are monitoring the follicular size by ultrasound instead of serum, instead of urinary LH kit. So here we are monitoring follicular size so that we want to detect when the follicle is reaching 18 to 19 millimeter. And there, instead of waiting for LH surge, what we will do is we will give SCG from outside 10,000 IU, and we will plan the ovulation time. So we know what time we are giving SCG, we know and we plan what time she will ovulate, and accordingly we will plan the transfer. So here, what modification you will see? Two important modifications in natural cycle protocol. One is that you will not monitor LH by urinary LH kit, you will monitor the follicle size. And here, second important modification is that you will give before LH surge, you will give SCG and control the time of ovulation. Again, it is possible only in ovulatory patients. Now, ovulation monitoring cycle protocol for FET means ovulation induction protocol. So here, what you can do in this protocol, from the second day, we will give either clomiphene citrate 100 milligram or letrozole 2.5 to 5 milligram from second day, and you will monitor follicular growth right from 7th day. Means 5 days you will give oral ovulogents. Okay, I have put in because even clomiphene citrate is a good drug, but it has got a negative side effect on the endometrium. So the first choice here is letrozole. So you give 5 days of letrozole. You can give even 5 milligram per day. And 7th day onwards, here you will start scanning the patient for follicular growth. Now, only in case if you don't see on 7th day follicle which is not beyond 10 millimeter, here you can add, thinking of adding low dose gonadotropins, that is HMG 75 IU, so that the recruited follicle will be pushed ahead for further dominant growth, because your HMG is going to keep the FSH levels in the body above threshold. And then you will see that a single 1 or 2 follicles are growing. And same way, once the follicle is 18, you will give SCG. Now, only problem or disadvantage which you have to monitor here in this sometimes when you are using HMG, that if you have 2 or 3 follicles dominant, then there is a high chance of premature LH surge, and you have to keep a monitoring on serum LH levels. And if it require some cases, not too many, because with this protocol, you will always see letrozole followed by HMG, maximum 1 or 2 follicles, and less chances of premature LH surge. But it is always better that you keep a track and make sure that there is no LH surge. And once you are documented no LH surge, LH is normal, then you give SCG and then plan frozen embryo transfer. This you can use it into anovulatory patients. So oral ovulogents, typically first choice. If you see that no, there is still not much follicular growth, then you can add HMG. Otherwise, letrozole fantastically gives you a single dominant follicular growth. Artificial cycle by HRT protocol, how can we do? Here, again, it's quite simple. Instead of endogenous E2, we are dependent from the exogenous estrogen. So right from second day of the cycle, you will start giving her estradiol valerate or estradiol hemihydrate. Starting dose should be either 4 milligram per day or 6 milligram per day. I always feel that when we are mimicking the natural cycle, and if you look at the natural cycle there, and if you look at the estrogen level graph, it is always rising. So I always feel that let's mimic it, because that graph has to be increasing estrogen levels. So I always prefer that you increase the dose by 2 milligram every 3 days later for at least 12 to 16 days. So if you have started for first 3 days 4 milligram per day, then next 3 days you give 6 milligram, then next 3 days you give 8 milligram, then next 3 days you give 10 milligram. So by the end of 15 to 16 days, the patient will be on 12 milligram per day and you will get a good adequate endometrial growth. Once you document by looking at the endometrial thickness, looking at the endometrial blood flow parameters and endometrium volume, all three parameters, then you can start progesterone and then you can plan a transfer. Again, what day of progesterone, we will come to that stage later when we are close to the embryo transfer day. But this is how you will plan your artificial cycle. Now, there is one modification you can do is we can do HRT cycle in a GnRH agonist downregulated cycle. Now, this is how you will typically plan. Here, the previous cycle of the treatment cycle, you will call the patient on 21st day. Okay. Now, this day you will give GnRH depot, which is 3.75 milligram intramuscularly. Now, here we have to observe if your patient is ovulatory, means regular cycles, you just give Lupride and tell her on 21 day and tell her to come back after 10 to 11 days. Because by the end of 10 to 11 days, she will complete her downregulation, as we know from our long GnRH agonist protocol, what we used to use it in ovarian stimulation protocol. So similarly, the downregulation will complete within 8 to 10 days. Also, she will get her menses. So the previous cycle endometrium is shedded off. Now, she is downregulated, and now on second day onwards, we will again start estrogen in the form of valerate or hemihydrate in a similar fashion what we discuss in a non-down-regulated HRT cycle, and further steps are almost same. Now here, many times, if you have done a frozen, vitrification cycle where you have stimulated follicle, you have recruited, you have formed the embryo and vitrified. Now, once a patient gets a menses, to follow this protocol, you have to wait for 21 days. Now, there is an alternative that you don't need to wait for 21 days. What you can do, as soon as after vitrification of embryo, from next menses only, on the second day, instead of waiting for 21 days, on the second day itself, you can give Lupride depot injection, and you can call after 11 days this patient, which is her 12th day of menses. Here, she will not get menses, of course, because there is no endometrium, but you have to monitor and confirm downregulation by checking on transvaginal scan that endometrium is thin. You have to check the estrogen levels, which has to be below 100, and you have to check the LH levels, which has to be below 5. If these three parameters are there on day 12, your downregulation is sure shot complete. And 13th day onwards, directly you can start giving estrogen. So this is also, you can save time instead of waiting and wasting for 3 months or 3 weeks. You can immediately following menses, second day you can start the cycle, and still you can do a downregulation and continue the HRT protocol. Now, with downregulation, you have one advantage that you yourself has a full control on the cycle in terms of whenever you want to start progesterone, you can start. You can schedule the embryo transfer as per your expectations. And of course, in downregulation is not possible in natural cycle FET protocol. So we have a, what we say, scheduling of cycle or embryo transfer that can be very easily possible. So for a person who is handling multiple centers, a person who is traveling on weekends, probably downregulated cycles are much, much better because they give you full control. When shall I start my progesterone? When shall I do? According to my schedule, I can plan my transfer. Now, this was in 2020, where effects of artificial cycles on GnRH agonist pre-treatment on frozen embryo transfer cycles. So all consecutive women undergoing HRT protocols, there were around 2,936 cycles or HRT with GnRH agonist pre-treatment. So non-downregulated cycles were compared with downregulated cycle. So they divided patients into 3 groups and they compared this, what is better. And they realized that especially the young patients who are less than 35 years, the clinical pregnancy rate is significantly better with downregulated cycles. Especially in endometriosis, again, the clinical pregnancy rate and live birth rate is significantly better in downregulated cycle. But, and if you look at the PCOS patient, the miscarriage rate was very, very low in downregulated cycle. So if you identify patients where we should do a downregulation compulsory, these are the 3 groups where you can think of doing a downregulated HRT cycles. Now, comparison of two mainstream protocols. That is, one we discussed about natural cycle, and second is the HRT cycle. What is better? So this was a comparison between two streams, and they found this particular study in 2022 by Yu Fu. They found that if you compare clinical pregnancy rate, live birth rate, miscarriage rate, absolutely no difference. Absolutely no difference between natural cycle or HRT. So this probably this paper showed us that fine, we can decide as per my convenience that okay, I'll put this patient, she's ovulatory, I can do a natural cycle. No, this is unovulatory. I can put her, for HRT cycle. So without compromising reproductive outcome. So any of these protocol is not superior than each other. But then 2 years before that, before that 2022 paper, they found that this paper made us realize that if you follow the HRT cycles in comparison with natural cycle, HRT cycles were associated with a higher incidence of hypertensive disorders of pregnancy, higher birth weight of the fetuses and the newborn babies, and higher incidence of preterm birth. So this was another 22 paper which says that because in HRT there is absence of corpus luteum, and corpus luteum produces products like relaxin, which is a very important regulator of deserialization, which predisposes women to preeclampsia. So because of absence of relaxin, these patients who are undergoing HRT, because there is no corpus luteum, they are predisposed to preeclampsia. And that exactly opposite happens in natural cycle or modified natural cycle, or even ovulation induction protocol, mild stimulation. You have a follicle growing, you are giving SCG, you have corpus luteum formation, so it produces relaxin, and it reduces the obstetric complications like severe pregnancy-induced hypertension. Again, when a meta-analysis was done and between these two protocols, they found that somehow these artificial cycles with HRT was associated with significant lower live birth rate in comparison with true natural cycle or modified natural cycle. And these natural cycles, they do have a higher chance of live birth and lower risk of PIH, PPH, and very preterm birth than compared to HRT cycle. Now, a very good study recently in Lancet 2024, July, in fact, they wanted to compare the live birth rate after one frozen embryo transfer cycle in ovulatory women, and they compared all three protocols. Now, we are just focusing on ovulatory patient. Shall we do natural cycle? Shall we do modified natural cycle, or HRT is still best for such patient? So two parameters they found major difference when natural was compared with HRT, and that is cancellation rate in first FET cycle. The natural cycle and modified natural cycle, almost 20% cases, that is 1 in 5 patient who is undergoing FET, we had to cancel it because of inadequate endometrial response or follicular response or low estrogen levels, but that didn't happen with HRT cycle. So that's the biggest advantage HRT. So even in ovulatory patients, you can think of HRT giving HRT as an endometrial preparation protocol without compromising any of the reproductive outcome parameters like live birth rate. Same in all the patients, 37, 33, and 34. So even if you look at the cancellation rate, it is too high. So when you plan patient FET cycle and you are discussing to them natural cycle and modified natural cycle, you need to counsel them that yes, there is a possibility that I may not get adequate response from your follicle or from your endometrium, and there is a higher chances of cancellation rate, and she has to be ready. And still, if you want to be safer, you can go for HRT cycle with that risk of development of some obstetric complications. Coming to the drugs which shall be used for endometrial preparation. So estradiol valerate versus estradiol hemihydrate. And this was our own original research paper. In fact, first in the world, that prospective randomized comparative trial between estradiol hemihydrate and estradiol valerate for endometrial preparation for frozen thawed embryo transfer. This was our presentation in ASRM 2020. Here, what we realized in our results, we had almost 103 patients, and we got it almost 75%, 75 patient out of 103. That comes to 72% pregnant. And when we compared the outcome parameters, what we realized, the implantation rate is significantly in favor of estradiol hemihydrate, 87 versus 71. The clinical pregnancy rate was 75 versus 60, though statistically not significant, but there was definitely a significant difference of 15% higher clinical pregnancy rate in estradiol hemihydrate. If you look at the most important parameter of my study was ongoing pregnancy rate, and that was 75% versus estradiol validate 53%, and that was statistically significant. So it gave me some insight that being hemihydrate, which is kind of a 17 beta isomer of estradiol, it acts with a potent action on estrogen receptors. So it gives you a better endometrial milieu in terms of thickness and endometrial blood flow, because of which, after successful implantation with a good oxygen supply, I think the ongoing pregnancy rate is significantly high. We did not find any difference in terms of endometrial thickness between both the drugs. Both were having mean of 10.9 and 10.9 only. Even the pulsatility index in zone 3 was not found, no difference between both the drugs. So those parameters are not changing, but the outcome is changing. So what we concluded is probably hemihydrate looks to be in much better in favor of achieving a better ongoing pregnancy rate when it comes to, and these all points are important when it comes to endometrial preparation in assisted cycles. So even we have to discuss about drugs and doses. Now, serum E2 levels in HRT cycles, whether it affects live birth, that is our question. So sometimes what we always say that in a natural cycle, when you have a single follicle, estrogen levels are only 125 to 200. So in fact, we get better pregnancy rate. That's what is our observation. So what happens in HRT cycle if you have a lower estrogen levels? So this was a good study done in 2021, where what happens is impact of estradiol on pregnancy outcomes in letrozole stimulated frozen embryo transfer cycle. So here, remember, when you use letrozole, it is a aromatase inhibitor. So it inhibits the conversion of testosterone to estrogen. So it affects the estrogen production. And in these patients, many times we do see that estrogen levels are below 100. And in few patients, it is above 100 also. So what happens, what will happen if there is a lower level and if it is above 91? So what is the outcome of this situation? So what they realize that in a clinical pregnancy rate is clinical miscarriage rate was almost 36% in these patients who had estrogen level less than 91, and those groups of patients who had more than 91, the clinical miscarriage rate was 8.8%. So even if you look at the live birth rate, that is showing a non-significant difference, though p-value is significant difference in terms of normal estrogen level. The live birth rate is better, but clinical pregnancy rate is higher and live birth rate is later if it is below 91. So you do natural cycle, you do HRT cycle, when you come across low estrogen levels, that is below 100, there is a higher chance of miscarriage rate and a higher chance or a lower chance of live birth. Now, this was another study in 2020, similar fashion, estradiol levels were compared. So one group were having estradiol less than 144. Second group had estradiol levels between 145 to 438. Third group had in fact more than 439, and they found live birth rate was not significantly different. Even estradiol levels were more than 400 or 500. So they did not find any association between serum estradiol levels in the late proliferative phase and live birth rate, even if it is high. So low is not good, but high is not a problem. How much high is okay? So of course, there is no literature evidence is suggesting that, okay, up to 1000 is okay, up to 1500 is okay. We don't have any evidence till now. But one of the few studies which again compared and they found similar result, that the miscarriage rate was significantly higher when estrogen levels were less than 100 picogram per ml. Right. Coming to now the next level where we can optimize our success rate, and that is cleavage stage versus blastocyst. So When we want to prepare our endometrium and protocol, again, we have to decide when I'm going to transfer, whether cleavage or blastocyst. So we know that if you go to the blastocyst stage, then your embryo selection is very precise because you know what quality of blastocyst it has developed. Of course, you cannot rule out looking at blastocyst that whether it is euploidic or aneuploidic. So you will have to take a help of non-invasive PGTA, or probably sometimes if in certain centers in globally they do a PGTA and find out. But in frozen embryo transfer cycle, this was a randomized cross-sectional study where 97 patients underwent blastocyst transfer and another 97 patients underwent cleavage stage transfer, and they found significantly better chemical pregnancy rate as well as clinical pregnancy rate was in favor of blastocyst transfer. In terms of any other parameters like preterm delivery, obstetric complications, there was no difference between these two. So there is no increase in obstetric complication, but you are having a better clinical pregnancy rate with a blastocyst transfer. Even this patient also proved that, especially patient who had experienced one failed fresh embryo transfer, even in those group, if you do a blastocyst transfer, the live birth rate is significantly in favor of blastocyst stage transfer. So I am convinced. I want to convince you that if you plan FET cycles, plan for blastocyst transfer instead of cleavage stage transfer. You will have a better clinical pregnancy rate. You will have a lesser miscarriage rate. Now, on what day of progesterone will you like to transfer blastocyst embryo? Now, this is very important, and this was a fantastic systematic review in 2021 by Dr. Sidan Mumusoglu, and he gave us a nice diagrammatic representation that if you are doing a HRT cycle, the moment you see a better endometrium, next day morning you start progesterone. So today we have done the scan, the endometrial milieu is fine. Tomorrow, if I start a progesterone, which is the first day of progesterone, then blastocyst transfer will fall on sixth day of progesterone. So that is very important. If you want to do a cleavage stage transfer, then it should be on fourth day of progesterone. So the first day is the day when you are starting 3 times progesterone. Now, when it comes to true natural cycle, when there is no intervention, so you are detecting the LS surge as we understood. The day you see LS surge and you have confirmed LS surge by serum LS levels, then next day is first day after the LS surge. Like that, sixth day from the LS surge, you will do a blastocyst transfer, and cleavage stage transfer you will do fourth day after the LS surge. So remember this slide, and I think it will be very, very easy for you. In modified natural cycle, there is a little change. In modified natural cycle, once the follicle is ready, you will give, that is 18 to 19 millimeter, you will give SCG. Do not count. That day of SCG is your 0 day. So you have given it today. So next day is your SCG, post SCG day 1. Like that, you will do post SCG 7th day blastocyst transfer, and cleavage day will be post SCG 5th day. So here there is one more day extra. So remember, if you follow this, you will not have out of the phase endometrial embryo transfer in a out of phase endometrium. Now, can we do a 6th day or 7th day progesterone blastocyst transfer? Then you have a blastocyst. What is the difference if I do on 6th day or 7th day in hormone replacement cycle? Because as per the previous systematic review, ideally it is to be done from on the 6th day of progesterone. But instead of 6th day, if I do a blastocyst on 7th day, is there any difference? So this study in 2020, they found that live birth rate were comparable. That was 36% for group A and B, even after adjustment of confounding factors. So there is no difference. Implantation window is wide enough for 2 to 3 days. You can still do a blastocyst transfer on day 6 of progesterone or day 7 of progesterone. There won't be any difference into live birth rate. Now, when you give progesterone, before embryo transfer, how much minimum progesterone level should be achieved? I think by this time, there are a lot of discussion into our conferences, and it has been very clear that if a serum progesterone levels on the day of embryo transfer, if it is less than 10, then there is a higher miscarriage rate. And at the same time, if these progesterone levels are above 10, even beyond 15, 20, 30, 40, it will not, it will give you, keep on giving you better ongoing pregnancy rate. So 10 is the very important cutoff, 10 nanogram per ml, below which try and avoid transfer, and anything about 10 is absolutely fine. Now, can serum progesterone levels predict the ongoing pregnancy rate? So this was a study which was again a prospective cohort study in 2019. They measured the serum progesterone levels on the day of transfer, and they followed additional tool to maximize ongoing pregnancy in a single euploid frozen blastocyst transfer. Now here, the blastocyst is selected properly. It's a euploid blastocyst, frozen blastocyst, euploid blastocyst, and only single has been transferred. So they noted down all the patients who were showing ongoing pregnancy, like group 1, 99 patient with showing presence of ongoing pregnancy rate and ongoing pregnancy, and 69 patient having absence of ongoing pregnancy. And they compared a progesterone level on the day of ET, what was there on the day of transfer, and they realized that those who were showing ongoing pregnancy with the support of 100 milligram intramuscular progesterone, the progesterone levels, they were mean were 28 in those patients who were having ongoing, and in absence of ongoing pregnancy, those levels were only 16.4. So they concluded from these all vast patients, they concluded that if you need a best of the ongoing pregnancy rate, the optimal cutoff value of progesterone level should be 20 or above 20. Means if on the day of transfer, if the progesterone levels are above 20, your ongoing pregnancy rate is much, much better. Now, also similarly, this was another study which clearly showed that even progesterone levels can be beyond 53 or even up to 100 and 144. Still, there is no difference. Your ongoing pregnancy rate keeps on increasing. So too much of progesterone is not at all bad in terms of achieving ongoing pregnancy rate. Now, last point is about which progesterone. So we know that Lotus 1 trial compared vaginal micronized progesterone versus dydrogesterone, and it clearly showed that there is no difference in ongoing pregnancy rate or live birth rate when you use any of these progesterone molecules for luteal phase support and for early pregnancy support. But this was a mid-run study in 2021, which gave us a different insight. It was a prospective cohort study. So 732 patients received vaginal progesterone 400 milligram twice a day, along with dydrogesterone 10 milligram twice. So both were used in 732 patients. And another patient group, 632 patients, received only dydrogesterone 10 milligram twice a day. And they found that the live birth rate was significantly in favor of, though the difference was only 6 to 7%, but it was significant by p-value, and it was in favor of giving combination of vaginal progesterone and dydrogesterone. And miscarriage rate, look at that miscarriage rate, the lowest 3.4%. I think that's something which is eye-opening, which if you use both of the progesterone. So friends, to summarize, despite the worldwide increase in FET for various indications, the search for best protocol to prepare the endometrium, we are still continue. Though HRT and natural cycle, which also include true and modified, are the most commonly used protocol, recent emerging evidence also suggests that mild ovarian stimulation may be a viable option. Currently, low quality evidence points towards natural cycle being superior to HRT, but that's a very low quality evidence. I feel that both are equally good, but in HRT cycle, caution is warranted since the early pregnancy loss rate seems to be high, and also there is an increased risk of hypertensive disorders in pregnancy in cycles without a corpus luteum. So I think we have to wait for more evidence that is it a really true statement when we'll have a larger studies. And regarding a warm blastocyst transfer, which should be our first preference, the timing about transfer evidence says that when it comes to HRT cycle, you can do it on 6th or 7th day of progesterone. When it is true natural cycle, you have to post LS surge, 6th day you will do blastocyst transfer. In modified natural cycle, post SCG 7th day you will do a blastocyst transfer. So friends, in the era of personalized medicine, the one size fits all strategy does not match the FET cycle. So select your patients properly, select your protocol properly, select your drugs properly, achieve the adequate levels, and do a blastocyst transfer. Success is no accident. It is hard work, perseverance, learning, studying, sacrifice, and most of all, love of what you are doing or learning to do. So thank you very much for the patient hearing, and thank you for me giving me this chance to present my data as well as important literature evidence for it's such a practical topic. And I really thank you, Charmila, for giving me that chance for my favorite topic to speak on. So over to you.
Wonderful talk, Kundan. You could hear that love which you have for the subject. And I hope everyone who attended understands like so much of work has gone and you've correlated everything. They just review an article and give us a message, but you did it with, you compared it and you gave us those results. Jem Kanan Madam has joined. Madam, can you give your thoughts
Yes,
on this beautiful lecture by Kundan?
yes. It's such a lovely lecture. Kundan always is up to the point, and I'm
Thank you
very
very much.
appreciative of it.
Thank you.
And of course, the era is now more with the microbiome, all those advanced things. But still, Kundan, yesterday I found a paper which has been in the Journal of Women's Health and Clinical Endocrinology, where, of course, the research is nowadays more in China only, where they have just compared FSH versus FSH plus HMG. The argument which is placed there is we always try to suppress the LH level so that we don't have a premature LH surge, premature ovulation, so that our the ovum pickup is appropriate. In
Right.
that eagerness, we do not have a thinking about how much the LH suppression is going to impact on the endometrial preparation. So in that, they have a paper in which a good number of average expected sample study has been done. And they have said, if you find the endometrium by day 9, 10, less than 5 mm, in those cases, they have found adding up HMG or recombinant LH. In the next 3-4 days, they have found the pregnancy rate to be increased by statistically significant. This is 61.5 versus 84.5%. Statistically significant they have given.
Yes.
I hope you also would have seen the paper. Because our AART people are from suburban areas of Chennai. We are not in Pune, we are not in Chennai. We are in Tiruvarur, Mayuram, Tanjavur, where they would like to have more ideas about this one. Would you comment on this? This is
Madam,
great
I
for
just wanted
LH this is supplementation.
yeah, I wanted to ask you this addition of HMG, you have done it in a natural cycle, are you talking about, or you're talking about
Yes,
HRT
in a
cycle?
normal, sorry, this is ovarian stimulation for normal responders like
Yes.
ovum donors, male factor infertility, tubal
Yes.
infertility, where the AMH is average.
Right. So I
Where,
think
see, we have every cycle, we can have surprises, With all
right.
these factors, this AMH is average. In those cases, with our this antagonist being given and getting an LH suppression, with 14 mm, 13 mm, we start giving antagonists, By 10, 11, we find the endometrium not expected at the level. In that case, they have done it.
Yes, I think your point is very valid. We can correlate this physiologically.
Yes.
See, like suppose if you are giving antagonists, so sometimes the antagonist reduces FSH and LH so low that even the estrogen production gets affected and endometrial growth really gets into stagnation. And to push this kind of situation and to rescue this situation, if you add HMG, HMG is going to act on that follicle, and it is going to allow that follicle to push that estrogen production immediately to come out of that shock of no FSH, no endogenous FSH, and it really rescue. So yes, endocrinologically, this is important, and that's why it is so important to monitor these cycles ultrasonographically. You have to correlate your endometrial thickness with your follicular size and also correlate your today's findings with your previous sonography findings. And then you have to use these drugs. So I think a very valid point you brought up here that yes, sometimes we do go and use antagonists, but at the same time, if we don't give additional stimulation, you will see that suddenly that follicle regression and endometrial also regression. So I think yes, your ultrasound monitoring will help you, and you need to take.
Thank you. Manjula, if you permit one more.
Yes, ma'am.
See, in this thing, frozen embryo transfer, many of us use only endometrial preparation. I think natural cycle and modified natural cycle are only 10 to 12%. 85% is frozen. In
Yeah.
that frozen cycle also, would you suggest this thing blastocyst transfer after we see the progesterone level
Yes.
by day 6, 7, or would you like to adapt it to a different level?
No, I think I will still in HRT cycle go for blastocyst transfer. Now, the first thing
Blastocyst
is very
transfer
important.
on what
Yes.
day and what is the criteria which you would
Yes.
like to take?
Yes. So what I do in my practice and looking at the evidence, say for example, today I find it that my endometrium is better and my myelu is better. Tomorrow morning,
Better means
better means what I discussed. The endometrial thickness has to be beyond 8 to 9 millimeter
8,
minimum.
9 mm.
Okay. Then the all PI which I discussed,
Yeah.
PI value has to be below 1. The PSV has to be above 10 in those subendometrial vessels. Endometrium volume may vary. It's not compulsory that it has to be beyond 5, but it has to be below 3. But this we have already tested before starting this ART cycle. But two important parameters, thickness and the blood flow parameters. Once you have achieved, you have 30-35 color Doppler signals nicely seen in subendometrial vessels, I find it this is good. Okay. Then we start progesterone. Now, what my own experience, so because evidence says that you do day 6 of progesterone, you do a blastocyst transfer. I showed you one paper that if you do a blastocyst transfer on day 7 also, you have a
Yes.
equal live birth rate. And I am doing this since last 15 years that I do my blastocyst transfer on 7th day of progesterone. Okay. And I found it the similar results that the what you achieve in terms of parameter is the lowest miscarriage rate. Okay. The level which you are going to achieve. So you need a good progesterone levels. And we try, and so what we do it in our practice is we check the progesterone level 1 day prior to the transfer, that is day 6 of progesterone. And we want those progesterone's level above 20. So we make sure that it has to be above 20. Then I plan my blastocyst transfer. So it is, we are sure, number one,
Yes.
that adequate progesterone level is achieved. Then next day morning, we thaw the embryo, and by around 1 o'clock, we do the transfer. So my findings, my own experience-based findings are, if you achieve these kind of protocols and going 1 day further, you will be able to achieve ongoing pregnancy rate of almost 63%, which is every year you will get it. And I know ongoing pregnancy 63% is a very challenging thing to get it. But I think with day 7, I think 1 day extra will make a lot of difference.
Good.
And
It also helps in weekend support.
absolutely, yes.
That is another thing. It is a blessing in disguise, weekend support. Thank you, Kundan. All the best for your future also. Wish
Thank
you
you.
soon to see you as a Vice President Foxy.
Oh, thank you so much.
One related question to that, Kundan, like there's a proverb in Tamil, like Sattila irukradha aappayila varun, we'll say. That is
What you have in the pot is
pot
what you
only,
get in your
spoon. You cannot get different. What is there in the
Yes.
pot only you'll get. So suppose a person has got an unexplained infertility and you've done a IVF cycle for her. Suppose a follicle is not forming a good endometrium, like natural cycle you're planning for her. And suppose a follicle is not good, will it form a bad endometrium? Is there something like that?
Yeah, I think it all depends on the follicular's capacity to produce estrogen levels. So you may have in this patient sometimes some cycles where follicle is growing nicely, but you look at the endometrium is not growing that way. Maybe between 5, 6 or 6.1 it stagnates. So if you check the estrogen levels in this at this level, you will typically realize that this patient who is during ovarian stimulation cycle showed a good endometrium. Now suddenly a good follicle, but endometrium is thin. And there is a defective folliculogenesis. So you will see estrogen levels 32, 41, 62, very low. So what is happening is the selected follicle is a defective follicle. It is probably there is something wrong with the granulosa cells. This follicle is not producing adequate estrogen. I think we have to leave this cycle because anyway the prognosis is bad. As I said, below 100 estrogen levels, very high miscarriage rate. even the implantation rates are going to be low if your endometrium is below 6 millimeter. I think best way to cancel this cycle. See, we have to always compare what we have seen it in the previous ovarian stimulation cycle. A patient who has grown her endometrium up to 9, 8.5 or even 10, I think if she is not growing beyond 6, there is something wrong. Either the source is wrong, either the circulatory levels are wrong. You have seen the endometrium, there is no problem in the endometrium. She has already shown a good growth. So something wrong. So this is what happens in natural cycles. You know, many times it has seen that natural cycle gets cancelled because of defective folliculogenesis, lower estrogen levels sometimes, or your endometrium is not correlating with your follicular size. So I think we need to understand that, you know, if you want to scheduling HRT is really good. Okay. But I think I will still like to wait for few more evidence that if HRT cycles are really increasing so much high levels of pregnancy induced, I will still like to wait for further, further papers. Even we are retrospectively calculating our incidence because we have experience of almost now 9 years of experience of using HRT cycles, and we are going to soon get our also evidence about how much obstetric complications we are expecting with HRT cycles. But I still feel that HRT cycle gives you a better control. HRT cycles will reduce your cancellation rates, and natural cycle you need to be very vigilant. Very close monitoring is required, and cancellation rates are higher. So I think that's the message I will like to give it to a lot of people.
And there is a thought that for a FET cycle, injection progesterone is much better compared to a vaginal progesterone or an oral progesterone. Is that right?
Yeah, I think I also have that opinion. But what I feel and what I do in my practice, which is I think slightly deviation from evidence base, that I do use intramuscular progesterone during those first 6 days. Okay. Because what I have realized that when you are using like a Midron study, dydrogesterone and micronized progesterone, still the circulatory levels, we don't get it in many percentage of cases, we don't get it beyond 20. Okay, they might be good 13, 15, 18, but we don't get it in 20. And we have realized that these patients, especially they need a good progesterone support in once they show the beta HCG, because their progesterone levels falls and below, and their desudalization is poor on ultrasound, their gestational sac is smaller, their fetal heart rate is in little lower range below between 100 to 120. So achieving good progesterone level by the day of transfer, I think that is very, very, very important, because your successful implantation, that is invasion by tropoblast to the spiral arterioles or arterioles, is going to decide the outcome of the pregnancy. And I think that's why you need a good progesterone. Once that progesterone is good, your desudalization is proper. Once the implantation or invasion is proper, I think the outcome definitely improves. So giving these 6 days will reduce your lot of trouble into early pregnancy time period, where you struggle giving, on the ultrasound when the sacs are low, fetal cardiac activity low, and you want to increase progesterone to increase the outcome. So what I do presently is once we start progesterone, we do give her 50 milligram of intramuscular for first 6 days. We check the levels. If the levels are, and they are always above 30. I'm sure once you they are always above 30. You will not come across any case where the levels are low. They are always above 30. And then after doing transfer, I do not give intramuscular progesterone. I just continue dydrogesterone and vaginal progesterone. And our usual findings are your ongoing pregnancy rate will be always above 60 to 63%. I mean, 60 to 63 is what average ongoing pregnancy rate we get. So I feel that there is a connection between your progesterone levels on the day of transfer and your outcome, which is most important, and that is ongoing. And that's why this is the critical time period before transfer. What you give and what thickness you achieve and what progesterone and how much you give will make a lot of difference in outcome.
Thank you so much, Kundan. There are some questions in the chat box.
Sure.
Dr. Gokilavani is asking, like, can you demonstrate a Doppler study of endometrial arteries? I think we'll have another class with Kundan for that. Yeah, so this is too short a time for that. And she's asking, would you like to prefer HCG 10,000 or 5,000 as a trigger in natural cycle?
I think it doesn't matter 5,000 is enough. Now the evidence is very clear that even 3,500 is enough for your as a trigger to use it. So your doses will not differ that just because it is a single follicle or multiple follicles. No, I think 5,000 is enough. You don't need 10,000 for the trigger.
Okay. And when should we start progesterone after giving an HCG injection?
Okay. Today, if I have given a SCG, tomorrow I need to start progesterone. That's very important.
Like any time period? How many hours after HCG?
Okay. So
36 hours. Yeah.
what we plan is, if I have to give today SCG, then I will plan it at 10 o'clock in the night. Okay. I have done the scan. Follicle is 18 to 19 ready. 10 o'clock in the night, I will give her SCG. Next day morning, I will ask her to start progesterone. And then the SCG, I will call her exactly 40 hours later. And also I confirm ovulation, though it is not required. Okay, though it is not required. And we just go by the same way. Then we follow that progesterone plus 7 is the blastocyst transfer.
Okay. Should we check estradiol level when the more than 18, I think 18 mm she went, 1.8 centimeters. Okay.
Okay. So you have, say, 18 millimeter follicle, but you have a good endometrial, like it is beyond 9 millimeter and a good endometrial blood flow, you do not need. Okay. But if the follicle is 18 and your endometrium is on a thinner side, you don't see those expected blood flow. I think, yes, you must know, because if it is low estrogen level, please cancel that cycle, because as we have seen, the higher miscarriage, clinical miscarriage rate is very, very high. It's almost it is 8 to 10 times higher than your more than 100. So cancel the cycle if estrogen levels are 100. So you can check it on the endometrium and then decide. It is not compulsory required for all patients, estrogen levels.
That question I think you asked, Dr. Tiruveni has asked the type of progesterone, where you have said that, but the dose in an HRT cycle, how much of vaginal progesterone would you like to give, and dydrogesterone, how much?
Yeah, I think I generally give natural vaginal progesterone. I give it 400 milligram 3 times a day. Though it looks higher, because I cannot assess my endometrial concentration of progesterone by circulatory levels. But I still prefer the more progesterone is more better outcome. So I personally give 400 3 times a day. But remember, let's understand the evidence, because evidence comes out of studying this, lots of patients, randomized studies. You need to give minimum 600 to 800 is something which you must follow. Okay. And I always feel that, when people are giving 400 twice a day, okay, so please understand that we need a sustained endometrial concentration or uterine concentration of progesterone. So please divide your doses in 3 times. Do not give 12 hourly. Please give it 8 hourly, so that you have a steady levels. So uterine contractions are going to be low. So instead of you are giving 800, but giving those 400 twice a day, instead of that, either you divide it like 300 3 times a day, or 200 3 times a day, or 400 3 times a day, but give it 3 times, so that the number of contractions are per hour are always same. They are low at any given time. And that's very important.
That's a very practical point.
Yeah.
And Dr. Gokilavan is again asking, like, do we have any other modality to improve endometrial thickness other than progesterone? I think she's asking about the add-ons, like sildenafil.
Okay. I feel that when you are monitoring endometrium in any protocol, you monitor blood flow. Now, suppose you have done estrogen levels and you found out that the thickness is good, the estrogen levels are good, but I don't see much endometrial blood flow. Okay, means number of signals in zone 3 are less. I think that is the only area where you will add sildenafil. And this is more useful generally in HRT cycles, because when you add sildenafil, you need at least 6 to 7 days of administration. You will not see quick changes into parameters like PIRI within 1 day or 2 days. You need to give at least 6 to 7 days. And that much time you don't get it in natural cycle and modified natural cycle. So I think better in HRT cycles, if you come across this scenario, sildenafil can be added. You can wait for 6-7 days. Once you see a better change, then you start progesterone. So the source is good, the levels are good, the problem is at subendometrium level. Okay, so there you can add sildenafil because it definitely improves the vascularity, and more than vascularity, whatever vascularity is there, it reduces the resistance in that vascularity. So the PI falls. So the moment you start seeing PI of 1.2, 1.1, 1.3, these are high in those circulations. So if you see this, sildenafil addition will reduce this PI below 1, and you will see that the vascularity has definitely improved into this.
RG9?
Yeah.
Use of RG9?
Either of them.
Or,
Either
okay,
you use sildenafil or you use RG9.
RG9.
But I think sildenafil is more effective than L-arginine because the absorption through vagina is very, very good. And there is one study which has compared for PI outcome between sildenafil, arginine, and vitamin E, and almost 92% patients who use sildenafil showed a significant reduction into PI in comparison with 81% in L-arginine patient, L-arginine group. So potency wise, sildenafil is better in reducing the PI than your L-arginine.
Right.
Though both drugs are good, but efficiency wise, sildenafil is more effective.
Dr. Priyadarshini, you said amazing lecture, sir. In case of a modified natural cycle, do we consider follicular rupture after HCG, or irrespective of the status of rupture, we
Yes.
go ahead and calculate HCG plus 7 for a blast transfer?
Yes. In fact, the recent evidence says that if you are doing a modified natural cycle and you know that follicle has become 14 or 15 millimeter today, and endometrium is already good, the thickness is good, blood flow is good, you don't need to wait for that follicle to become 18. Means if you want to schedule your transfer according to your schedule, and you want to start and give a trigger today also at 14, 15, you can definitely give it because your documentation of ovulation is not required. You just want to convert that follicle into corpus luteum. That's it. Okay. So even random SCG you can give irrespective of follicle size. Maybe even 14, 15, your endometrium is good. You can give SCG, start progesterone next day. You don't need to document whether that follicle was ruptured, was it luteinized unruptured follicle, doesn't matter. It is still going to produce progesterone, and it is still going to produce those relaxins. So it doesn't matter. You don't need to wait for the size, but only look at your endometrial picture.
Okay.
That is most important for frozen embryo transfer.
Okay. And how do you deal with thickened endometrial thickness in the fundus alone? Dr. Gokilavan is asking.
Okay. So when you see only thickness at first half, I mean not first half, upper half of the cavity, and lower half, I hope you're talking about that.
Yes, she's
And
asking.
the upper half has got a very good thickness and the lower half is absolutely thinned out. I mean, very minimal endometrium we see. I think if you look at these cavities by 3D ultrasound, you will always notice that the lower cavity is too much narrow in that area. And I always feel that lateral metroplasty in these patients is really, really useful. There is a fibrous tissue deposition into this area. There is no mobilization of stem cells. The endometrium is not growing at all in that region. And we need a good endometrium. Worthwhile putting a scope and look at the cavity and do a lateral metroplasty in this patient. You do see an increase in the cavity volume so nicely. You will see that endometrium is now growing 6 to 7 millimeter thickness in that lower part, which is also important. Your blood supply improves. I think it gives you a much better fantastic. So what we did in last 3 years is we are noticing pre-hysteroscopy, means pre-lateral metroplasty, all 3 parameters: thickness, blood flow pictures, and volume. And also post-hysteroscopy, next cycle, 16 day, we are again notifying these 3 pictures and we are comparing. So that, because in molecular level, we are not able to judge how endometrium receptivity is improving, but how endometrium parameters are improving. So those we are keeping a track of it for all the patients so that tomorrow we will have some conclusion and some picture evidence that how the things improve.
Thank you, Kundan. I think you answered the question of refract within endometrium also. And the next question is, should E2 level be checked if the endometrial thickness is less than 8 mm?
Oh, yes. I think I will suggest yes. You must check estrogen levels because you may have a low estrogen. I think we have already discussed this point that if the estrogen, because there even do not think that giving HRT will always give you better picture. We have seen this enough times that patients are on 15 or 16 milligram of estrogen per day and they just don't grow up endometrium. And when we check their estrogen levels, they come very low, 60, 62. You cannot have so low levels of estrogen. So either there is a problem in the batch of your estradiol supplementation, or there is a problem in the absorption of estrogen from the GI tract, and that's why the estrogens are low and that's why their endometrium is not growing. So recently we did have this in the month of June, that consecutive 6-7 patients were not doing so well with same molecule, and we checked the estrogen levels and then we realized that all estrogen levels are so low. So we changed the batch. In fact, we changed the molecule. That was estradiol hemihydrate only, but we changed the product and we found the difference immediately. Okay, so sometimes the batch which you have received for the drug which you are using, sometimes they are ineffective. So yes, I think estrogen is must in such scenario. You must check, because if it is not a good endometrial myelu, your ongoing pregnancy rate is going to go low.
And Dr. Madhu is asking, will you give progesterone injection 4 hours before an ET if you find that the progesterone level is low?
Okay, I think it's not for the ET. If you're talking about ET, what is important is that you need a minimal contractions. So you don't need to give 4 hours before. Just at least half an hour to 1 hour before is enough. That is to keep your uterine contraction lowest at the time of transfer. So that's a complete different thing. Now, suppose I am giving dydrogesterone and natural vaginal progesterone. These two combination as a luteal phase support, and the progesterone levels are below 9 or 10, maybe 8 or maybe 7. Now, we know that the miscarriage rate is going to be high. Now, there are two papers which I come across in this scenario. One paper, what they did is a rescue protocol. They added aqueous progesterone 25 microgram twice a day for rest of the 13 days of luteal phase. And they found no difference in pregnancy rate or miscarriage rate. They found that with that addition, you still get away and you will not increase the miscarriage rate. Or else, second protocol which they have seen that if you are given only micronized vaginal progesterone, the second paper, only micronized progesterone, and your progesterone levels are low, you can add dydrogesterone here, 10 milligram 3 times, so that you give more progesterone. Also, they found that there is no difference in protocol. But the only problem is that intramuscular for another 13 days is always a concern, because there is a lot of induration. Sometimes even they are very, very painful. So what I feel, you can use aqueous progesterone in that case, suppose if it is low. So aqueous progesterone 25 microgram twice a day subcutaneously patient can take on her own. I think it's still going to be better protocol, and you can still go ahead with the embryo transfer.
Thank you. Of progesterone, the SR preparation.
SR preparation, I think I personally have a zero experience. Even the literature has got a zero experience. So there are hardly any papers which were well done studies which are saying that SR preparations are better and they are giving you better progesterone levels. I think I won't recommend them.
Okay. And the dose of sildenafil?
25 milligram vaginally 3 times a day, ideally.
And yeah. And Dr. Madhu is asking, do you give 6 days of progesterone and go for a blastocyst transfer on day 7, sir?
Yes,
no.
That's right.
No. And use of vaginal estrogens, Dr. Victoria is asking.
Oh, I think be very careful. One of the estradiol hemihydrate, which was recommended to be used by pharmaceutical company, I did it for 5 patients. Believe me, within 10 days of vaginal progesterone without increasing dose. So if you give estradiol hemihydrate 2 milligram 3 times vaginally, within 10 days, estrogen levels were in the range of 30 to 100 around. All my 5 patients, I had to cancel my embryo transfer procedure, because those levels were very, very high. And it was not only once. We did it from a very standard lab and 2-3 times before we cancelling this cycle. And every time the levels were high.
Okay.
So vaginal estradiol hemihydrate, I have experience. I don't know about estradiol valerate vaginally. I haven't used it any time. But hemihydrate, be careful. the absorption is super duper good. But within 10 days, estrogen is endometrium myelo is good, but the estrogen levels are very, very high. We did it, and I think couple of months back, and we cancelled all 5 cycles.
Okay.
So little be careful about it. Though there is no literature reporting of these cases about vaginal hemihydrate, but we tried using it and we had a very bad experience about very, very high estrogen levels in the circulation.
Thank you, Kundan, because usually you're supposed to finish in 1 hour. Because of that wonderful talk you gave, I think doubts are just cropping up with everybody's mind. But we'll call you again for another lecture because you're supposed to finish by at least 8 o'clock today. So thank you so much. Like it has been an eye-opening lecture, as one of the delegates said. But beautiful lecture. So much clarity was there. I think everybody had their minds cleared of all those cobwebs. Lots of appreciation for you from all the delegates. I'd like to thank you on behalf of this for another meeting. Thank you so much. Thank you.
Thank you, sir.
Bye.
Thank you for the wonderful lecture, sir. Thank you.